literacy? Everybody, excellent, okay. I have a bunch of slides here. Some we may be going through faster than others, depending on where everybody is. A little bit about what we're talking about health literacy is what many people understand as health literacy is actually a fairly narrow view of what it is. And starting about a year and a half ago, the National Education Association and some other folks nationwide have begun to realize that health literacy instruction or training, if you will, really needs to begin in the public schools and private schools. Go there, in order to create a health literate population. And I'll be talking about that a little bit more. I've spent some time over the last year and a half bouncing around to a bunch of places and a bunch of different audiences, basically doing my cheerleading routine about why we need to pay attention to health literacy. Most of the time I'm speaking to folks who are not health educators, because the assumption is we all at least understand the need for folks to be health literate. But the other thing I've come to realize is not all health educators embrace the full scope of what we mean when we talk about health literacy. So I'm going to spend some time today doing a number of things. One is getting everybody on the same page about what it is that we're talking about when we talk about health literacy. The second is to talk a little bit about why we all need to begin to and move forward in thinking about how we can make health literacy one of the skills that in our schools and districts everybody is helping to establish. And thirdly, what might be the role of the health educator in the school in making this happen. There's a couple places we'll stop and I'll ask you some questions, a couple places where you don't ask me questions, although ask me questions whatever you want. And we'll see where we are as we skip through the slides. So they give me a little, I'm going to see if this works. I almost, oh, that works. Okay, so we have to think about what is health literacy. Well, I got three definitions up there. One from the Institute of Medicine that wrote a very large report in 2004 looking at health literacy. A lot of what that report did was look at it from the framework of the interaction of the healthcare community and folks. The second is from the National Health Education Standards, and the third is from a man named Donald Nutbeam, who's down in Australia, but has published lots of things about health literacy. You see a lot of words up there, but basically we're talking about health literacy has the idea of we have some knowledge about health, but also we have the ability to use that knowledge. And thirdly, we follow through with the knowledge and the ability to take some sort of action. And I'm going to send, by the way, I'm going to send this PowerPoint thing to all of you. I'm trying to save some trees. And I'm going to send it to all of you with the contact that we have, that and the fact that I was still fiddling with it last night, but you know, I'm going to do that. Okay, so again, health literacy is more than just knowing stuff about health. And one of the themes you'll see of the day is that health education is not anymore, if it ever really was, about the facts and just the facts. In fact, it's much more than just about the facts. It's not just knowing. Folks need the ability and the confidence to use the knowledge they have about health. And health literacy is dependent on skills and context. Anybody, and there were a few of you in here, whoever had me as a student, and we talk about self-efficacy as being behavior specific. I may think I'm wonderfully confident in, performing physical activity every single day for the required amounts, but I'm not confident at all in my ability to prepare low-fat meals. I'm going to be exercising a whole lot more than I am going to be eating low-fat meals or preparing them at home. We're beginning to understand that we can be health literate more so in some contexts than in others, and that becomes important. All right, this woman is just amazing. Rima Rudd, I forget how old she is. She's fairly old. She's at the Harvard School of Public Health. She stands in the middle of a room. I saw her speak, and there were about 150 people in the room, and Everybody was riveted to this woman. Anyway, she's done a lot of work in adult health literacy. And when you take a look at what's up there, we're going to flesh this out a little bit. Health literacy, we're talking basic literacy skills, reading related skills. You need those to be health literate. You also need writing skills, speaking skills, listening skills, math skills, and conceptual knowledge skills or in critical thinking types of things. We're bringing in that. So begin to take a look at, well, what are the pieces of this? Anybody scared yet? Okay, good. Ability to read, understand, and act on health information in everyday life. Two other lovely young women, well, not so young. Tammy Benham-Deal, a colleague of mine in Wyoming, and I have done some work with the National Education Association in health literacy, and we're essentially saying the same thing, that reading, writing, numeracy, those types of things are part of being health literate. All right. Some of you may be sitting here saying reading, writing, math, speaking, not my job. Right? Yeah, some of you are smiling. That's not my job. We got other folks in school that are supposed to be doing that. Well, guess what? On some level, it is your job. So we're going to talk a little bit about how that might work. Not to be scary, no one's asking you to teach calculus or even anything close to calculus, but if you think about it, what do we do when we teach our students how to calculate the percentage of their calories they got from fat on any given day? It's math, right? We ask them to read an article from a reputable source and write a little paragraph about what it is that they got from that article. It's literacy skills. Okay? We ask them to make a presentation to their fellow students in a way that their fellow students can understand. Speaking skills. We're doing it. This is not new stuff. But part of what we need to think about is how do we do these things in a way that's purposeful to get us to health literacy. It's an asset to be built and not a problem to be solved. Even when you look in the professional literature and you read about health literacy, a lot of it talks about this is a huge problem. People are not health literate. It creates all these issues. We're going to talk about some of those. But if we come at it from the perspective of this is an asset, and we are all about asset building, right? You want to build those assets so that we can have healthy folks. All right. Let me ask you a minute. Why do you think this idea of health literacy? I know some things about health. I understand them. I'm confident I can do them. I can use this information to take action. So when I do that, why is it important to be able to do that? Anybody, just throw out some stuff. Why? Why do we need to do that?
Essential to the quality of anyone's life.
Absolutely.
The quality of society.
Okay, yeah, improves the quality of anybody's life. Other thoughts?
Continues education.
Okay, good. Anybody else?
Want a real thought?
Lack of health.
I'll give you a sarcastic thought.
Oh, wait.
It makes us more legitimate in the eyes of our colleagues.
Excellent.
So they've studied and showed that health literacy, lack of health literacy is costing the country billions of dollars in terms of healthcare costs.
Money. Yes.
Kids aren't winning road.
It eliminates many of the fundamental barriers to learning.
Okay, good. It eliminates some of the barriers to learning. Absolutely. Okay, let's take a look. You got some excellent ones there. You're a good group. Briefly go over these. If we look at why we need to think about health literacy, in addition to its important, health information and health services is becoming increasingly more complex. How we have to use the systems, the services that we have to engage with, the number of healthcare practitioners that we need to engage with, that creates a situation where the more health literate we are, the better we're able to navigate the system. Some of the work we're doing with the National Education Association is actually funded by United Health, which is one of those tremendously large health insurance companies. They got into the health literacy business just before health reform was passed because they began to see that whatever health reform was passed, it was going to mean that the health insurance companies had to do something different. Okay, that's fine. They were okay with that, but they also realized that if the folks that were members of their health insurance or paid for their own health insurance, if they were more health literate and thus more healthy, they made more money. So, and because of the complexity and the information. Okay, more opportunities and responsibilities for self-management. I think we're beginning to see that. Many folks think this is a very good thing. We're going to manage our chronic diseases. We're going to manage our own health. We have some control over it. That's very good. Many folks say that, well, that's not really fair because the healthcare system is abdicating some of their own responsibilities there, and there's a whole bunch of folks in between, but the reality is that we are responsible more so than we probably were 25, 30 years ago for self-management. Impact of health on academic performance. And I spoke to a bunch of administrators last week, and this one gets their ears to widen and they're to engage with you, if we can talk about that. Understand and use knowledge, making informed decisions about all of those things, and advocate for yourself and others. One of the pieces that I'm personally really interested in is if we have more health literate folks, are we going to be better at advocating for the health-related things that we need? I would certainly hypothesize that that would be true, but there's nothing quite out there that directly relates to those two, but I definitely think it's there, and there's some preliminary stuff. All right, a couple of other things. Healthy People 2020, they're just getting ready to release those. There's objectives in there about health literacy. They're all basically about the idea that we need to ensure that our children graduate with the skills to help them live healthier through their lifespan, just what you were talking about. But this is going to frame funding, it's going to frame conferences, it's going to frame materials, it's going to frame a lot of things for the next 10 years, and it clearly points out that education has a role in creating a health literate population. And we're not just talking about adults, we're talking about kids. And the second piece is related to what folks need to function well in the 21st century. We're going to take a look at that a little bit later, the skills that we talk about with health literacy and the 21st century skills, and the National Health Education Standards have a lot of overlap, which is both good for us in that we can be doing lots of things at once, but it's also a little bit of a challenge, I think. All right, somebody mentioned money before. This was just published. Estimated cost of limited health literacy is 1.6 to 3.6 trillion United States dollars directly. Indirectly, we have a whole lot of other economic cost related to illness and disability and lost time and all sorts of things like that, and then the bigger piece about poor quality of life. And to give you some context there, the most recent national assessment of adult health literacy, over 75 million adults had only basic or below basic health literacy. That's a lot of folks. The work in adult health literacy, by the way, also clearly shows that someone can be literate, but not be health literate. That's where the context piece comes in there. Everybody's going, yeah, you all know people like that, right? All right. All right. I've given you our family. We're going to, a couple of points through the next several slides, stop and talk about our family of Romanian immigrants. We have a grandmother. You can read that. She doesn't really speak English. She lives alone in a small apartment. She's an adult onset diabetic. She's insulin dependent and she's on Medicare. Her son, Nikolai, he's full-time employed in the service industry. He's hypertensive, overweight, pre-diabetes. Has health insurance, but it has high deductibles and high co-pays and lots of things like that. And in making this up, you know, he's actually a bonus because many folks in the service industry, of course, don't have access to health insurance. He's somewhat bilingual, but still mostly speaks Romanian. His wife, Anna, works part-time as a custodian in a local school. She's overweight. She smokes. She does have the equivalent of a high school diploma. There are two children, Stefan and Adriana. somewhat bilingual, but English is really their first language. They both have asthma, and they live in a medium-sized city in central New York. Pick one. All right, so we're going to get back to them. You have your sheet to refer to. All right, so put the public skills aside for a minute. What do we know about the impact? How does health literacy impact us in our actions? Well, we know that it impacts how and why we navigate the healthcare system, including what we share with healthcare providers. The healthcare folks will say, how can you say we're responsible for all this stuff if our clients, our patients, are not sharing with us everything that they need to be sharing with us? There's lots of reasons why that might not be happening. Health literacy is a part of that, understanding what I need to share with my healthcare provider. All right, health literacy affects if, how, and how well we perform our self-care, if, how, and how well we perform chronic disease management, how well we understand concepts like risk. I have a 16-year-old who just got his learner's permit. I'm learning a whole lot about understanding risk right now. To do that sort of stuff. And then health-related decisions we might make. Our level of health literacy affects all of those things. Not a surprise to most of you or all of you sitting in this room, I'm sure. All right. Give you a minute to look at this while I take a sip of my coffee. This is just an example. It is not an exhaustive list. All right. Some tasks we might have to do as a healthcare consumer or just a person. We might have to locate appropriate services, apply for health insurance, and provide information to our healthcare providers. So if we look at what tools are available to us to do these things, we see if we're trying to locate services, we have website, phone book, maps. What sort of skills do we need to use a website, to use a map, to use a phone book? We have a certain set of skills we need to do. Asking and following directions. A couple decades ago, a woman named Deborah Tannen did a whole lot of work in communication, and one of the big things that got a lot of press was that women will ask directions and men will not ask directions. And apparently there's a whole lot of truth to that. It's not universal, but there's enough behind it. But if we take that differently, there's a whole lot of cultural pieces that would drive whether someone would stop and ask for directions or not ask for directions, or ask for directions from their healthcare providers or not ask for directions. How should I do this? Type of a thing. So we need to think about those things. We need to be able to use appropriate search terms. We need to be able to evaluate whether the websites that came up when we used those search terms are valid and reliable sources. You all know that. 75 million adults in the United States don't. So how can we get the kids to know that before they become adults? And you look at some of the other tools and skills that we have that are just a small part of a health literate person can use those tools, can identify that those are the tools that they need, and use those skills. Now, take a look at the skills. I'm not going to ask for specifics, but I'm going to ask you to raise your hand if in your health education classroom or a health education classroom you know about, any of those skills are taught directly. Excellent. More so than I generally see. Good work. Very good work. When we look across, and it's really preliminary scanning, but a lot of health educators don't think that those skills are part of what they need to be doing. Not my job. All right. You have your look at you have your family description. I want you to take, 3-4 minutes, write on the back of the page, talk to your neighbor, whatever. Come up with 2 or 3 examples of how you think being low in health literacy would affect the family or any member of the family.
Yeah, I didn't get
Of which? The family? The family?
anything.
Have one up here.
There's more here. I'll pay $5 to go turn that. Not uncomfortable. $10 the lady.
They probably won't let me do it, so. It's usually set.
Okay, one,
Is it? Don't panic, we're good.
This one.
It's all locked up.
Tell us facilities.
Warmer in this room than they
That's what we were saying.
I told Amy.
We were trying not to have you move around too much.
Amy's to get me to I'm ready to do the should have I already started writing on the paper.
So is smoking big in the room? I'm asking, is smoking big, tobacco big?
Yeah, Eastern Europe, big. All the way big. To say like this is a composite of folks I know. All right, about one more minute, then we'll see what some of you have.
Tell me which one to write, I'll write it. I write it.
All right, let's see what some of you came up with. And Greg, you want to offer us one? Got an idea?
For the grandmother, I was saying, because she has very poor English skills, speaking and the understanding, it may be harder for patient education, which could increase the chances that she's not going to take care of herself as well as she should, which increases the chance that there's going to be additional health issues with the diabetes, and quality of life goes down, healthcare costs go up. That's
Oh, you played that out to the end
Yeah,
game. All
yeah.
right, Amy, what you got? Anything?
I do. The low health literacy, they would not know that the smoking is aggravating their children's asthma.
Okay, absolutely, absolutely. Tracy?
Just lack of tobacco knowledge in general and how that could be affecting their health.
Okay, good. Anybody have anything different?
Not seeking treatment because they don't know they should, or
Deductible.
Okay,
so.
good.
I went to the deductible, keeping him and the family from obtaining regular medical care to avoid long-term complications dealing with all of this and avoiding diabetes for him.
Okay, good. I'm going to stop right there in the interest of time. They got me on a very tight leash. Okay, you might have, we already have some of these, but you might have some more. Can't understand the written materials provided by the healthcare provider. So if all the healthcare provider does is hand them a trifold or a handout, that's not going to do anybody any good. They didn't understand the form, so they did not sign up for appropriate health insurance. They could not calculate appropriate dosages of over-the-counter medicine or anything else that they're doing. Poor at assessing the validity of the websites. The teenagers may have taught the parents how to search the web, but the teenagers probably didn't have a conversation with their parents about what's valid and not valid when the stuff comes up. The healthcare provider may have talked too fast and used too many big words for these folks. And what the adult health literacy stuff finds is that in many cases in this place, the people who are low literacy, whether it's literacy in their second language, literacy in their first language, very often have some level of shame about that and don't say, I didn't understand that. So do that. Can't read a food label, they're afraid to let on they didn't understand. The foods that are suggested that they should be eating are not available and they don't know what to do about them. So those are just some, I'm sure there are many more. But we can see that this idea of having some knowledge, understanding it, using it, and being confident to use it can play out in a whole number of different ways that can affect the health and quality of life of this family. All right, 1 month ago was released the National Action Plan to Improve Health Literacy, big long document. I spent the time for you all and read through it and pulled out what's most important right now for all of us to understand. 2 slides. First one is about their vision is of a society that provides everybody with access to accurate and actionable health information. In other words, it's absolutely true, and it's what you need to know, not a whole lot of other stuff packed around it. Person-centered health information and services, that's the whole piece about healthcare providers and interactions and all sorts of things like that, and supports lifelong learning and skills to promote good health. That's you guys, more so than anything else. Okay, there are 7 goals in the action plan. 3 of these goals apply directly to the educational system. 1, incorporate accurate, standards-based, and developmentally appropriate health and science information. I'll tell you from experience, that doesn't happen everywhere. So that's one of the goals. Increase basic research and development, implementation, and evaluation practices. And a small piece of that that's important for you all to be part of this goal. Are you assessing whether or not your students are becoming more health literate in the true sense of the word? Or are you just giving them a test that asks them to know facts? Are you assessing how do they use the facts? And are they confident in doing the skills that you want them to have? Really, really important. And then increase the dissemination and use of evidence-based health literacy practices and interventions. And I'm going to say a lot of what we already do in health education is related to health literacy, but not everything we do is evidence-based. So we're going to focus you on that part. All right, what's the role of the schools in all of this? Basically, this is my disclaimer slide here. We know that we as individuals and the healthcare system, as well as the educational system, are collectively responsible for this concept of health literacy. We're just going to focus on the educational system's role at this point, so we don't talk about all those other things. All right, how many of you have heard of 21st Century Skills Movement? I know some of you, because I saw you last week. I'm not going to talk a whole lot about these, but we're going to place health literacy as one of the core subject themes in the 21st Century Skills Framework. Basically, it says that health literacy is one of the ways that we can teach 21st century skills, and that health literacy is important for everybody to have to function well in the 21st century. And I have some resources if I take a look at. All sorts of bunch of things in there, but basically the 21st century skills are grouped into 3 groups: learning and innovation skills, information, media, and technology skills, and life and career skills. Now take 30 seconds and look at the examples of those skills. Anybody find them familiar to anything?
Standards.
Yeah?
Standards.
Yeah, the standards, absolutely. They're very, very similar to the National Health Education Standards. So the 21st century skills and health are very complementary, and if not very much the same. So what I'm asking to think about is not really doing anything new and different. It's just thinking about it in a slightly different way and connecting it to something that is larger than just the health education classroom. 21st century skills are about everybody. So everybody needs to be part of this. Okay. What do we know about developing health literacy? We know, like just about anything in education, it's a hierarchical process. You have to start with easier things first, and you build upon those. So we need reading, writing, and numeracy skills at some level to build health literacy. The speaking stuff can come pretty early. Before a child can read, before a child can write really well, we certainly, in some preschool situations, we can teach children speaking skills. How do you share with your parents what you're feeling in your body? When do you share that? Who do you share those with? Those sorts of things. How do you express that you don't understand what somebody's asking you to do with regard to your health? You can do that speaking, and then we move into the reading and writing. Now, we need to think about communicating in a dynamic way, and all that means is one of the next level skills is how do we take information we're getting, process it, and use it in a communication framework about health. And that we can critically analyze health information and use it to enhance our health. That's kind of a higher level skill. Think about that. Again, this is not new stuff, but we're going to think about it. How does this relate to building health and health literacy? So I said before, developing health literacy fits very well into any existing framework in PS through 12. It's not just about health education. But, as you'll see, health educators need to drive some of people's thinking about your job as health literacy too. All right, whoop, I did that. Building health literacy. All right, you guys already, good for you, mentioned the National Health Education Standards. You saw that there's a very nice overlap between the standards and the 21st century skills. The standards really identify those action pieces that are involved in being a health literate individual. If we have all the skills that are in the standards, we're going to be pretty health literate. Absolutely. I'm going to argue that the coordinated school health program model sets up a wonderful environment that provides the context for our kids to practice health literacy skills before they go out in the real world. I know all of you know that in order for us to be good at skills and to be confident to engage in behavior, we need to be able to practice these skills in a safe environment. If our school building, if our school districts have some semblance of a coordinated program, this really provides a safe environment for the students to practice health literacy skills before they do it in the real world. Okay, we talked about that. Anybody have any questions about the 8 component model? I'm working under the assumption that most of you at least have some idea that it exists. Okay. All right, so if you look at this very busy graphic, I tried to use, I'm a visual learner, so I put everything into charts and graphs. So anyway, what I'm trying to say here, on the left is the coordinated school health program model that builds health literacy. I said that. I've also argued that all the other folks, all the other disciplines also are part of this idea of building health literacy. We need to do a much better job of connecting those two systems. Much, much better. Where do they connect most logically and in a way that those administrative folks last week I talked to said, okay, that kind of makes sense, is if we talk about the disciplines. Health education is part of our educational piece, and so is physical education. So those folks need to connect, you all need to connect better with your other disciplinary folks in conversations about curricula activities that can promote health literacy. It's hard. I know that. Been there, done that. But it's really, really critical. Anybody have any comments or questions about what this is representing?
Preaching to the choir.
Okay. All right. This one is another busy way to basically say you have your school stuff here and your school district a little bit out there, and then you have the community. So your school and your district exist within your community. If you build a health literate school, if you build a health literate district, or a school and a district that are working on improving health literacy, it's going to benefit the larger community. By the end of the school year, nope. Over time, absolutely. It's going to take a while. And this is education's real goal here, is to have health literate, is to have healthy communities, and a piece of that is health literacy. Sandy.
Just kind of going back to your last slide, anybody have any thoughts? I train health educators and physical educators, and have been both over the last 25 years, K through 12 and higher education. And I think the thing that I've been just most sort of disturbed about is this is great conceptually, but to go way back just sort of to the grassroots, we don't even, I see this, I do mostly phys ed right now, but I've done health, but K through 12, we're not even talking with our own colleagues in a school district, K-12, about curriculum first, let alone those of you here are mostly health educators. I mean, I came from Pennsylvania, now I'm in New York, so most of you just do health ed, right? But you don't even talk to phys ed people. So we've got to kind of, I mean, this is great, but we got to go back and talk to our discipline-specific folks, whether you're health or PE, K through 12 first, on a regular process, systematic basis. Then we've got to talk to our other folks who are either health educators or physical educators within a district. Because we're never, you know, united we stand, divided we fall. We're never going to get to this next level by ourselves. And those of you sitting here in this room, you can't do it all yourself, and you probably do because you're here, you care, you're the doers, and you get burned out. So you've got to get, you know, the masses behind you. And we talk about baby steps. Go back and get your K-12 people talking first. And I don't think a lot of you, is there a lot of elementary health going on in New York?
No.
No.
They're supposed to be, but
They're supposed to, I know, right. So
It's a nice thought.
It's a nice thought, right.
Right.
So that might not be so much of a case, but you have elementary PE people and elementary classroom teachers that are doing your science, your nutrition, your drugs. So what are you doing to get all those folks together? So sorry, but this is great, but how do you get there is you gotta
hold that thought.
gotta be there.
Or hold that question.
Move forward.
We'll talk about some of the baby steps in a minute. How am I doing on time? Okay, there's my clock. I got 7 minutes. Okay. Y'all seem really well versed with the standards, so I'm not even going to spend a whole lot of time on there. Those are the national standards. They're all skills based. The core concepts, the knowledge piece, many folks still think of health education as just knowledge delivery, is only one of the standards. Okay. I gave you a crosswalk, and again, in the interest of time, we're not going to spend a whole lot of time there. But what Sandy was just talking about, Marty, you got one? Okay. I'm not going to go over this, but you can spend some quality time with this on your own over the summer. We see that lined up the National Health Education Standards, the 21st Century Skills, and the New York State. We're going to start with Health Elementary Standards.
Thank you.
This crosswalk is a way to begin to have that conversation with some of your colleagues about how can you help us create a health literate population. If your students are health literate and healthy, they're going to learn better. They're going to do better on those pesky little standardized tests. that in some form or other you all are getting evaluated on. Okay? You can have a conversation, and I've seen these conversations happen, and some light bulbs go on with folks if you begin to say, all right, you're an elementary school teacher, here's an elementary health standard, look at this 21st century skill, and that relates to these other things that you need to do. There is absolutely no reason why elementary school teachers cannot use health examples in teaching ELA standards, in teaching math standards, in teaching all of those things. And if you all can have a conversation with your folks about just that, not even help me, this is going to help you get to where you need to do, because kids are going to be healthier. Yeah, it's going to help me a little bit, but it's going to help you. This is hard. It's hard. We've had some success having these conversations with individual building principals. When the building principals get it, it goes a long way. My experience over the last 5 years has been the elementary folks are actually a whole lot easier to work with than the secondary folks. And from the reaction, you all get that too. But it's a good place to start. So, action number 1, have these conversations. Begin to have these conversations with the best person in your situation that is going to listen. That might be some other teachers, it might be a principal, it might be somebody else. I don't know in your particular case who that might be.
I teach in a real small community, think Mayberry.
Okay.
Okay. And at the end of the road,
Mm-hmm.
well, oftentimes we'll sit down with our administrators and say why this child didn't make it. And that's the door. That's the key to the door, because this one had anorexia, this one went to jail, this one had substance abuse problems. And the real barriers to learning in terms of their performance that they get evaluated on are health issues.
Oh, absolutely. And I don't have that slide with me. I apologize. But absolutely true. And I'll send you a slide. I'll send everybody this slide. Conceptually, the idea, and I've had pretty good results with this, is the idea that if you look at, for example, graduation dropout rates, okay? You trace dropout rates back. What do we know about dropout rates? Teen pregnancy, okay? That's a pretty big thing. What do we know about teen pregnancy? Alcohol use is often involved. We won't even talk about the sex stuff. We'll just talk about alcohol use. What do we know about alcohol use? Generally, tobacco. If they started using tobacco, they move into alcohol, generally. What do we know about tobacco use or any sorts of things like that? The kids who are lower on the literacy, not health literacy, literacy, are more likely to begin to engage in those behaviors at a younger age. This is why we all need to be concerned about literacy, period, and why everybody needs to be concerned about health literacy, because if we are teaching literacy, we're going to then help with the health problems, and if we're teaching health literacy, even better. That. We have dropouts, we have under and unemployment, right? Which, if they stay in that nice small community, feeds back to the cycle all over again. So the bigger picture, the conversation sometimes works. You're absolutely right, it doesn't always work. But if you get a crack in health literacy, that literacy piece, it can be a really magic word if you're trying to expand and get everybody on. And if you link the literacy with the health problems, you begin to get people to listen. And in the interest of time, I'm going to get to a couple of things. Okay, I said all of those things, so we're going to move. And we're not going to do that, but you think about the idea, how would the standards help those two high school kids in that family? You might have talked about if they had the national health education skills, if they had health literacy infused across some, even some of their subject matter disciplines, we might see that these two would be able to advocate for improved environmental conditions that would then help the asthma, both in their house but also elsewhere. They would understand what asthma was, its developing triggers, and be able to recognize the early signs of an impending attack and get ahead of it. communicate to parents and teachers when they need care, comply with the healthcare practitioner's recommended behavior. They might have decided not to smoke if they were health literate, or refuse cigarettes. They might be setting a personal goal to reduce the number of times they have to go to the hospital if they were more health literate. So we don't just have, I'm managing what I have, but we have a bigger picture of I might do something about creating a better environment and getting ahead of my thing. All right, so what's your role, finally? Standards-based curriculum and lessons, please. Because the National Health Education Standards are so linked to what health literacy is and the 21st century skills, you as the health educators, if you are doing standards-based lessons, you are improving health literacy. Do that. Incorporate the 21st century skills actively. Think about what that is. Work from the coordinated school health program model or something like it. If you're not there yet, you advocate for something like it, and you all need to take the lead at that. That's the way that it is. Doesn't mean you are doing everything. It means that you are coordinating, you are cajoling, you are keeping things together, you are pointing in the direction, you are facilitating all of those things. You're going to work toward cross-disciplinary planning for health literacy skills. Pick one skill, perhaps, to start with. One of the National Health Education Standards, perhaps. One that you can clearly argue leads itself well to learning 21st century skills. You're going to be able to, if you can get even an example, you get a math person to start using some health examples, and the world doesn't explode and the walls don't fall in and the kids don't start failing their regents. That one baby step is going to get some other folks. And guess what? If the kids are using health examples to learn math that are relevant to their lives, they're going to be a little bit more engaged in math than they would be otherwise. And that's another good argument to use. Evidence-based practice, skills and context, both in your own classroom. And what are those contexts that your students that you are teaching are most likely to find themselves in their current lives and a little bit further out? And apply it to the real world. We're still seeing a whole bunch of folks teaching health in, using examples and contexts that don't really exist in the real world anymore, or maybe perhaps never did. So we need to think about that. Like I said, I'm going to send this to everybody, but these are some links to some of the things I talked about. And when I send it to you, you can click on them and go there and take a look at that. All right, comments, questions, a little bit of a cheerleading, a little bit of correction. I'm around all day, so, if you want to have more conversation, we can say it.
Just a tool that you might want to look at is HEAP, if you're not familiar with it, HEAP. Health. It comes from the Health Education Assessment Project, but HEAP has a binder around literacy. And it's a great tool, if you're not familiar with it, to give to your elementary school teachers, because it's filled with books, K through 6, that help them, that they can use in their reading groups and their reading circles, have in their library, but they're all health content and skill based. So it's just when you have to have that conversation, they say, what do I do? Hand them this. Say, here's a starting place.
At my BOCES, we have a school that handles emotionally disturbed and severely handicapped kids. And just for fun, I was on the CDC website. They have a diabetes education series for kids, and it's a Native American based text, and so they're using it as a cultural text. They're using it also to talk about nutrition education, and they're using it in the art class.
Excellent.
And they're using it as a community read, which means every single student in the school is going to read this same book and talk about those same themes. And it's free on the CDC website, and they have the big hunkin' books for the teachers to have. It's a really good book, and it comes with the DVD and reads it out loud. And so I mean that would.
And that's a really good example.
It's one of them is called Tricky Treats, another one is called Knees High. If you go on the diabetes publications website, I'll send you the link, Laura.
All right.
So it's a really good book, and they're using it on all those different levels. I'm just excited that they're using it to talk about the nutrition stuff.
And related to that, another piece where you can perhaps begin to make some changes, if you use teaming in your schools in any way, shape, or form, a lot of middle schools do a lot of teaming. I've seen some teams work very, very well together where across all the disciplines they pick a theme and they all do a project and they work and they have there is absolutely no reason that the theme that a team could be working around could not be health. So if you can encourage them that whatever theme that they're using for a year is related to health, in Cortland recently they did environmental health as their theme. And they did some really nice things. They worked on advocacy skills. They worked on some other things. I have no idea. Portland folks will be here this afternoon. I don't know if their health folks had any input into that. Off the top of my head, my son did it. But I went through. But what they did and what they were reading was about environmental health. But they did ELA work there, and the math folks worked it in. And that's a really nice way to plan and get this stuff in there because, let's face it, health is a standalone in many places. And I know many folks feel kind of not really connected to the rest of what's going on in the curriculum. So anything that we can do to be more connected, it both helps us as professionals, but it also helps the kids think of health in a different way. When I supervise student teachers and I sit there and I watch sometimes, the attitudes of the kids and, they often they don't think it's very important. Because they only get it for this much, and because it's separate, and because they don't see it anywhere else.
Okay, I'm going to break in.
You're going to break in.
My class. I've been around. I was at Penn State. I started off as a high school health teacher outside of Boston. I'm now doing phys ed, so I do both. I'm dual certified, and I train people dual certified, throughout the years. So I always say, I feel like the cycle is going around. It used to be health and PE, then we separated, now we're coming back together, and I think we can do more united, but anyways, that's another workshop. Anyways, just real quick, I have been a national trainer for the CDC, the Centers for Disease Control, in their curriculum analysis tools. I'm starting my 4th year, actually, with the physical education curriculum analysis tool, and I'm on my 2nd year with the health education curriculum analysis tool, really, that just came out. Some of you said, I used the health education curriculum analysis tool years ago. Well, maybe you piloted it or something, but it really just officially was approved and came out not quite 2 years ago. So I've done more with PECat than I have with HeatCat, but the reality is the process is the same. I personally, last summer, worked as a paid consultant for a commercial curriculum company, which will remain anonymous. When they asked me to do the HeatCat on their 108 lesson plans, their 5 online modules, and 1,000 other website pages. It was stupid of me to say yes, but I did it. And I always told them one person should never evaluate a curriculum. It should be a team. So you're getting Sandy's warped ideas about what you are doing. However, I feel really confident in the fact that I used the HeatCat tool a lot. So I feel credible that I've done it, I've used it, and I've shared it with the commercial industry about the quality of their written documents. And so before I even show you, this is just an overview, but I'm going to talk with you more than really talk about slides, so you have them in front of you. Both HeatCat and Keycat, you have them first. So the HeatCat, and you really need a binder, or a big clip. So this is the HeatCat. It is a tool that we will use, that you will go back and find a team of people to use, preferably your wellness policy groups or your school health council groups, something like that. And this is a tool with scoring rubrics to help you analyze your written curriculum only. Okay? That's the Reader's Digest condensed version there. To analyze written curriculum only. Because the CDC and I believe that the foundation of any quality health education program is a quality written curriculum. I've worked with school districts that people, they get red and embarrassed and go, I don't even have a written curriculum. I said, I know, that's okay. and I've done this throughout the United States, mostly in the Northeast, really, if you're trying to redesign a curriculum or write a curriculum, this is also a great tool to give you sort of that framework of what should be in it. What should I be teaching? What should be in my curriculum? And you have to know that the HeatCat and the Keycat are based on national standards. They're not based on the state of New York standards. And that's been a sort of a learning thing for me coming to New York in the last 2 years. New York is sort of like, if it's not invented here, it doesn't exist mentality, a little bit. So this has not been very popular in New York, to be honest with you. All right, I've done 4 trainings in Pennsylvania. I've been in all of the New England states 3 times. I've been in Ohio 4 times. New York, I've done it twice and hardly anybody shows up. So you need to decide whether this is a tool for you to use or if you want to stick with sort of New York stuff. But the reality is New York should have embedded in it a lot of the national stuff. You would hope it does, to a certain degree. So anyways, that's the tool. Now, we have one for Fit Health. We have one for Phys Ed. Anyone in here do Phys Ed also? Oh, okay. So, like I said, I'm much more of a, I've done this a lot more just because it's been out longer, the Keycat. These are brochures. Take them to your friends, your colleagues, your administrators. We talked about advocacy. Bonni did last time, making change. You know who your biggest advocates are for change? Because I do a whole piece on advocacy. Get parents. Get a loud-mouthed, obnoxious parent that loves you and loves what you do. I mean, one parent shuts down a sex ed program. A couple loudmouths can really boost up a program, especially if they have some credentials after their last name or they're well-respected in the community. Make buddy-buddy with them. Send them to the school board meeting. Feed them the material. Get them fired up, right? Because you can't do it all. It's hard when you're there. So get some. I used to have a stay-home mom with a PhD in like public health who down in State College who didn't have a job. Oh, she was great. I just told her what to say and what to do, and she'd go and raise hell and get things changed. So those are good advocates to have. I haven't gotten to my slides yet. Anyway, I told you I don't use slides much. Just backing up on the documents. They are free to you. They are free to your school district at the CDC website. So go to CDC-Healthy Youth, or just Google HeatCat, Keycat. You can get all the materials that you have in front of you free. They'll ship you boxes of it. They want to get rid of it, okay? They have PowerPoint slides there, which this isn't even theirs. This is another group's PowerPoint. But the CDC has PowerPoint slides. They want you to use them. They want you to disseminate them. They want you to go to school boards. They want you to get your loudmouth parents on board. So they want this material to be shared. This is the only tool that exists right now in the United States. It's been the first tool to exist in the United States to evaluate written curriculum. And they developed it because nothing existed, all right, at a national level. I think it's exciting that the federal government finally is saying, oh my gosh, we got a mess out there, and we need to start in schools, and curriculum's a place to start, and geez, we've never paid attention to it. So the fact that the federal government is paying attention to this, I think, is exciting to me, and I prepare future phys ed teachers right now, hopefully soon in the future health teachers as well. But I said, this is a good time to be in our profession, to be honest with you, because the federal government's saying, hey, we got to do something about this. So you can get all these materials free of cost. All right. I've talked about most of this, really. So, why do we have that? It's because we need good written curriculum, and it was produced by the CDC and some of the top national health folks. Sue Telejohn, if you know that name, out of Toledo, Greg, that's your advisor. Yep. She was key in writing the HeatCat. I've done a lot of trainings with her. She's probably the best person out there doing elementary and middle health ed.
It is amazing.
Yeah,
stuff.
so this was written and developed by some of the best folks in health education in our country. Okay. Why do we want the HeatCat? To help you select health education materials, whether commercially, off-the-shelf materials, or to help you develop your own health curriculum. It gives you guidance. How many of you have to make decisions about, how many of you purchase commercial curricula? Do you do that? Okay, one. I mean, I don't.
We don't use it.
Yeah, you don't use it.
But health, they give you a good deal on it.
Yeah. I mean, my first and that's what this was designed originally for, was to look at commercial curricula. Well, in phys ed world, there is now one commercial curriculum out there. But it can really help you analyze your written curriculum that you have. And if you don't have a document, or you haven't looked at it since 1956, maybe you pull it off the shelf and you can look at it with this. Or it can help you redesign and invigorate. Who can use this? Teachers, obviously, administrators, curriculum developers, people at BOCES, those of us in higher ed. I actually just got done piloting the Keycat. I'm going to do HeatCat soon. for higher ed faculty, because we need to produce students that know how to use this stuff. Yeah,
Yeah, in my,
curriculum class.
yeah, I actually have my students use this and the school health
Health
index.
index, good,
Yeah.
good.
So they're trained, very familiar with it. And
Yeah.
when they leave.
Good. What's exciting, in August, I'm a beta tester. Somehow I just keep saying I'll do it. I'm a beta tester. All of this is going online, finally. All right? So this tool will be online. So if you're all here from Binghamton School District or something, you can all go and work online and make changes, and that'll be great. Because the paper-based thing is for someone who did 108 lesson plans and 5 modules online, I had piles of photocopies, and I ended up making spreadsheets, and it was a nightmare paper-wise. So this is going to be going online in your lifetime, hopefully. Okay. What are the areas that this tool will look at? Obviously, it looks at the critical health behaviors. This little supplement that you've got, this little teeny skinny package, sex and personal health and wellness were the last ones to be approved by the United States Department of Health and Human Services, obviously sex. So this just came out about, I don't know, 9 months ago or something. So if you see some of my slides that don't have those words, sex and personal health, I've tried to add them in there just because it wasn't approved until like 9 months ago. So this needs to be put into your big binder. These are the supplements. I believe environmental and consumer health is not in there. They like to think that it spirals throughout. Okay. Once again, I already said this, good written curriculum gives you a good health education program, we hope, which helps influence students' ability to improve healthy behaviors and give you healthy behaviors and outcomes. As Bonni talked about health literacy is spiraling throughout this tool. So let's take a quick glance. These are how the HeatCat is broken down by chapters. All right. It's just another thing to throw out there. The CDC provides free trainings. It used to be at the state level. That's what I did all my training. I'd go to the Ohio State Department of Ed, and 100 teachers would show up, and I'd do an all-day training. They have 1-day trainings, 2-day trainings, 2-hour overviews. They have them at state conventions, national conventions. But now they seem to have a lot of money, and they want to share this. So if you want a HeatCat trainer to come to your school district, go to that CDC website and ask for that. You might just get one, and it's free to you. All you have to do is provide the room, technology, and maybe a snack. Free. Okay, it's free. They want to get this out. Better yet is if some of you BOCE people could do a regional thing and get more people coming. I'm still learning how New York works. So, but regional, more people is good. Instead of going, they're not going to, you have to have a minimum of 10 people that show up or they won't pay for somebody to come. Because they give us an honorarium and travel, and it wouldn't necessarily be me. There's lots of people in the Northeast that can do this. Okay. So anyways, overview, general instruction. You tell me when I got it cut off. Okay. You can read the chapters there. But what's interesting is, I'm just going to go real quick here. I want you to turn to a couple pages. Read the directions on this thing. You don't need a trainer. You can do this yourself. But sometimes it's more fun with a trainer. But there's directions. There's instructions about how to use it. But go to chapter, where am I at? Chapter 2. Starts on 2.1. Chapter 2. You can look on, you don't even have to, you can just look for something if you want. The chapter 2 is where you would, I should have told you to open that up first. Let me just go over it, because if you open it, it's going to fly all over the place. Let's say you have, how many of you have a school health committee or a wellness council or something like that? You have parents on it, and maybe medical people that don't know anything about health. Well, chapter 2 would help, because it's a description of your health curriculum if you have one. And they could say, oh, okay, it's got this, it covers this grades, and it's got this many, it was published by, this person, 1956, that's kind of old. So it's just kind of an overview of what makes up your health program. It's an informational form, so to speak. Then if you go to chapter 3, right, chapter 3 is a summary sheet that summarizes your scores. Because you're going to do scoring. Basically, you have rubrics and you have checklists that you're going to go through as a team, not as an individual. All right, K through 12. The whole kit and caboodle. Now, maybe you don't have K through 6, so you do what you have. Right? Chapter 4 contains tools to help analyze and score important characteristics of any health education curriculum. You're going to look at things such as accuracy, accessibility, feasibility, and affordability. Is it culturally relevant to your population? Is it affordable? Are people certified in your schools? You know, do you have the resources available to do this? That's especially if you're buying a prepackaged curriculum. If you see that it's not affordable, that's going to cost $20,000, there's no need to even look at the content. Don't even bother, because you got a $1,000 budget given to you. So these are questions that will be asked in sort of a rubric scoring guide about your written curriculum. Curriculum Fundamentals is Chapter 5. It contains tools to help analyze and score characteristics of any curriculum. So it's going to ask you questions about learning objectives, about teacher material design, instructional strategies. It's going to say, is there role playing? Is there group work? Is there cooperative learning going on? Oh, I can't tell that from my written curriculum. Why not? Anybody here a new teacher in the last 3 years? Wouldn't it have been nice when you went to your school district if they handed you a written curriculum that gave you all this cool information that you knew what to do? I was a brand new teacher, and they said, oh, develop a curriculum. I was like, what's that? I don't know what that is. And I bought Health Skills for Life because, you know what? It had a pretty yellow binder. That's why I bought it. There was my criteria.
Well, you can reuse the binder.
Oh, yeah.
Because they'll give you money for curriculum, but they won't give you money.
But good curriculum fundamentals handed to a new teacher might ensure better, not that you're doing a bad job, but might ensure better teaching, you know, it's sort of like mentoring in a box. Okay. Promotion of norms that value positive health behaviors. That's cool. We want that to happen. And then the chapter 6 and beyond is really content that we start to look at. And there's the content and the pages, obviously the sex part, this was before the sex part was okay. And in each module, there's going to be a rubric and a scoring guide that asks you about knowledge and skills. All right? It's going to ask you about knowledge and skills, and it aligns with the National Health Education Standards. Oh, and see that part? This takes time? Yes. Quadruple your time that you think you're going to devote to it. So, national standards. This is what the curriculum tool is based on. Basically, the standards, as you know, tell you what students should be able to know and do. And I'll tell you, the eye-opening thing for most teachers is, standard 1 is really the concepts. 2 through 6 is the doing part. It's the skill-based. And that's where when I analyzed this commercial company, I sent it back and they go, oh my God, you fail. No, there's not failing grade. They said, we're terrible. I said, well, yeah, you're all content-based. It's just content. Content. That's all it was. There was nothing about skills. I said, well, we assumed. I said, no. There wasn't even an action verb anywhere in your assessment. And they're going, holy cow. Because they're trying to get noticed by the CDC. And the CDC said, how you doing on HeatCat? What's HeatCat tell you about your program? And I just slammed them, basically. HeatCat slammed them. Because they didn't have one action verb. So skills are action verbs, right? If you're looking at goals and objectives, your skills are action verbs. Demonstrate, apply, do. You know the standards. That's where they are. So just a quickie thing. Curriculum example. So I'm going to give you a quick little quiz here. You don't have to answer out loud, but identify harmful effects, blah, blah, blah. Is that a concept or a skill? Concept. Ta-da! All right. So these are kind of the examples that the HeatCat would give you to help people understand the difference between concept and a skill. And most of you are here. You do a lot of this. You might know the difference, but a lot of folks don't. Advocate. Concept or skill? Skill. Okay. Skill. Describe. Concept. Assess personal fitness levels. Skill. Okay. So demonstrate effective persuasion skills. Skills. So you get the idea. So the Keycat will be asking questions in grade clusters. Grade clusters like K2, 3-5, 6-8, 9-12. And it'll be giving you examples of, and they're just examples. You might have other examples. Whether you are teaching or whether students are learning, I should say, and are getting those skills for standards 2 through 6. So standards 1 we talked about are concept-based. Usually I do this with a tobacco curriculum. We bring it, we go through it when I have at least 2 hours, not 10 minutes. And as I said, standards 2, 3 are analyzing skills. So when they analyze the skill, the HeatCat includes student examples for each topic and skill area, provides student skill learning application score sheets, teacher instruction and skill assessment score sheets, and guiding questions under these assessment categories corresponds with stages of skill development. So they've even built into this sort of developmental skill development questions. Like I said, I've been doing this for about 4 years. I've been so impressed with what's gone into this tool. Same thing with PECat. That's what I knew first. They're sequential, they're progressive, they're developmentally appropriate, K through 12, they're standards-based, and the content aligns with the assessment. Oh, cool. And as I said, if you go through this, what do you get out? What's the outcome of what you get? In the PCAT, you have some scoring grids and you get some visual graphics of how well you're doing. With the HeatCat, you're really just sort of looking at gaps, low scores versus high scores in your rubric. A bunch of 4s would be sort of high, a bunch of 0s and 1s would be sort of low. And it gives you data-driven decision-making to your administrators to say, we're really high on core concepts around health. But oh my gosh, we have a bunch of 0s in advocacy. We have a whole bunch of 0s in interpersonal communication skills. So next year when you give me money to go to professional development, or when you're going to go for grants in health education, we need to get stuff that's going to help this program integrate more advocacy and interpersonal skills. Data-driven decision making, evidence-based practices. These tools help you develop and produce data about your curriculum, about your written curriculum. Okay? It's not about your teaching. It's not about how you're doing in front of the classroom. It's about what is written. Because that's the fundamental document that should drive everything else you do. And if you come out of doing this and see huge gaps in certain standard areas, then you say, okay, that's what we need to work on. We don't need to redo the whole thing. Let's this year just work on advocacy. And maybe next year we work on interpersonal skills. Was I at 20 minutes? I got 5 more minutes. Okay. So I know that was a really a rough overview. What I'd like to do is sort of open it up for questions and thoughts. And you're still sitting there going, oh my God, what you just talked about? Yes.
I anticipate doing this, there would be some people feeling overly criticized.
Oh yeah. Such as who?
Well, the people who develop the curriculum. I'm in a unique position. I'm the only health instructor in my district.
Well, who developed it?
Me. What was it before? 1956-ish.
Yeah, so I wouldn't feel bad. This is bringing up to speed. You're revamping.
Yeah. There are people, like I'm just saying, because the PE department too, they look at some of these tools, because we started the index too, as it being a critical thing, and being a what the gap analysis, finding out what you're not doing. It's not meant to be finger pointing, but it's
not
like,
at all.
Let's fix
I mean,
this.
I always talk about it as a programmatic. This isn't even about a program. This is about a written document. So this is not about the program.
Right.
This is not about the teaching. This is not about the people. This is about what's in writing.
Right.
And that's how I always frame it. Now, School Health Index might be a little bit more broad. And then in phys ed, we have the STARS program, which is more programmatic, like what's actually coming out of what learning is actually really occurring. That could be a little bit more defensive. But if you say, look, this is, it's 2010, folks. We care, I always say step back and look at the bigger picture. We all care about children, we care about children's health. And so the best way to do it is to really examine critically our written document. And if we care, we're all in the same, we're not pointing fingers, we care about children's health. The math people do this with their curriculum. That's the other thing I always say. If you want to be, I spend a lot of time working with PE people who are below health people. All right, in the pecking order, I would argue with you about that. I say, if you want academic respect, then let's start doing academic practices, such as assessing our written curriculum and revamping it. We do it in math, we do it in science, we do it in reading. Why are we not doing it in health and PE? And here's our opportunity to do it. I have found with administrators, this tool says, they go, oh my gosh, I had no idea this could be such an academically rigorous discipline and how important it is. Yeah.
But we still need a test, I'm sorry.
I'm sorry, go
We
ahead.
still need
You have
either.
support from the state until there's a
I know.
mandate, a state assessment.
There, I know.
And
That's
that's
the
the big
dirty little
problem. School
secret.
districts
Until
aren't
anybody
doing
holds
this
us
well,
accountable,
so-
nobody really cares.
Well,
But
no,
that-
it's to hold them accountable
Well,
too.
yeah.
I mean, because I think we hold ourselves
Right.
accountable, but
The
they
state
have to
level,
be
right?
able, that has to be public. The parents can make a decision on where they're going to move.
Well,
based on some of that.
so, and here's where I get to the advocacy piece. Then this is where you get your parents on board. Because I don't know if there's gonna be a state test, and quite frankly, we have to be careful what we ask for, okay? I don't know if there's gonna be a national test. I'm worried to death they're gonna have fitness gram and BMI going on for phys ed. We'll be done. Okay, schools, we can't fix the problem, you all know that. We're just a piece of it. So be careful what we ask for. But you can get parents educated with there's a lot of academic, data coming out that says healthy kids learn better. Duh, we know that. But now the CDC is publishing it. You can get some of that at their website. You take that to PTAs, PTOs. You get your loud, obnoxious parents that are gung-ho health. You know, get the nutheads that run 50 miles a day and are big into, they're doctors and lawyers. You know, you get those people that information, and then they go and fight your fire at the administrative level. Say, look, my kids, I want them getting into Harvard. They gotta have health. They gotta have fitness. I mean, seriously. Now, I come out of Syracuse City Schools. We don't have a lot of those parents. All right, I'm dealing with a very culturally diverse population of 63 different languages. 95% of kids are on free and reduced lunch. Okay, we talk about parental advocacy there. It comes down to like safety and drugs and violence, and how do we use this as a way to say it'll help us keep our kids off the street. So you've got to get, I think, the parental piece, because you're right. No one's given us a test, and I don't know if we want a test. But there's the
Or
lack of,
even the support, not just the assessment.
well,
but
because
the
there's no
support.
accountability. We're not being held accountable.
Well, was there one guy in charge of?
Yeah.
Yeah, Owen, right? That's
Yeah,
it?
Owen.
Yeah, and he doesn't,
And
he's not
Trish
very,
does phys ed.
not very receptive,
Yeah.
really. Or a big advocate, or a big rah-rah.
Yeah.
It's sad.
I just have one comment, is just, piggyback on a lot of these federal grants and programs that are in the schools, like your safe schools grants and any of the programs that really foster and promote healthy students.
Safe and drug-free schools
And
as
that
well.
could be a good grassroots
Yes.
way
It
to
would be.
infuse it.
And back to Bonnie's thing, bringing people together. Okay. One
Yeah,
question.
Just in relationship to what Suzanne said, I know that I do a K-6 health program for school districts, and I've gone through to relook at it using HeatCat, and it's just helped me even on an individual basis. I mean, schools can use this to evaluate the whole, but as a teacher, you can go back, and we know we're supposed to use skills, but they give you great ideas for the kinds of questions you can ask to give that action you need. So even as an individual, it's a wonderful tool. And if you're doing the national standards, I truly believe you're hitting most of the states.
Oh, yeah.
Thank you very much.
Just one quick
Yes.
question. If a person comes in, a trainer, will they help you actually, if we did it as a day of training?
2 day.
It's 2 days.
If you want to actually work on your document.
That's what my question.
2 day.
Answer my question. Thank you so much.
We would, on a 1 day, you would get the opportunity to start having that discussion.
Competencies and responsibilities needed by the person who's in charge of that program in a school district. And so that's the course that I teach, and Donna has taught, that actually does this particular assessment project that we have. And we facilitate it with area schools, and we've done just shy of 40 different school buildings assessments now in central New York. So it's a sizable group of schools. We've done all of Cortland County schools, and some have been reassessments. And we make recommendations for improvement based on what the assessment reveals. And probably, Amy, you could chime in anytime you want to. And we try to provide them with some resources to help them address the challenges that they find in that. And we try to avoid the word weaknesses and talk to them about challenges. And if I talk to you about your weakness, you're not going to be too happy with me, right? I can say, here's a challenge for you. You say, man, I can do that. So Donna and Bonni actually also helped with this. Looked at the schools that we had done in the summer of 2006 and the fall of 2007. They actually looked at 25 of the buildings that we had assessed, and did a follow-up assessment of this whole process to see how this partnership with the college and the schools was working, and how many of the schools were able actually to institutionalize some of the recommendations that we had made in the training modules that the students prepare and deliver to the schools. And they had a 27-item questionnaire, and it was done by a telephone interview. And they found that 40% of the Healthy School team and district-wide teams actually still met on a regular basis. And that's pretty impressive, because sometimes schools will only pull together a team just to do this assessment. Okay? And the whole idea of a coordinated school health program is to have people who are actually ongoing in this process and focusing on it as a group of people who are willing to work and commit to making the changes happen. 65% received monies as a result of having done their assessment. And more grants are now requiring you to do some sort of an assessment of your program. So if you don't go into that grant writing with that information, you're not as likely to get funded. And over about 3/4 actually made some changes in their policies, and that will tie in with the policy business we're going to talk about in a second. And again, 3/4 reported that they actually had improved some of their health-related programming. That sometimes meant that they actually changed some of their curricula. That means that they had actually maybe done something for staff, which is a forgotten piece in all of that 8 modules. The staff health and wellness promotion is often forgotten. And a lot of them reported that they really were much more aware of what was involved in this. I find that awareness piece is really interesting, because a lot of times by the time the students go back to present to the school district the results, they say, oh, we already did that. Just raising their level of awareness of what could be done is impetus for them to go ahead and step forward and do it. Disappointing to me was this finding. Only 1/4 of them reported that parents were much more aware. And when we present this finder, and there's a disc in here that has the whole report, it's got the PowerPoint presentation that the students do with all the recommendations for each of the components and for the overall building. And we always say, and take that and put it on your website and take it to your faculty meetings. There's a script in here. The last thing is a script with what they actually say with every slide. Take it and use it with your parents. Use it with your community. And they do a pretty good job within their own buildings. But outside the building, it's another world. And sometimes that doesn't get as far as we'd like to have seen it. And 70% reported that they now have a healthier environment. So there are things within the environment, like simply changing some of the stuff in the vending machines. This was nice. They all felt that they had actually the opportunity to take an active role in the school health index process. And we go in ahead of time, and I meet with the administrators and try to be very clear about what we will and will not be able to do for them, and set the stage for the team of students coming in to actually conduct the assessment, and tell them what they're going to get and show them a sample so that they know what the expectations are and what we plan to do. I found that is much more helpful. When I used to do it by phone, I think people had certain expectations that, even though they got something like this, they didn't think we did enough. So 92% of them felt that they were able to shape the action and implementation of their action plans. They actually, the things that we discovered for them were really real problems that they had the ability to address. And they left feeling that they had the knowledge to make the improvements in their program, and continued therefore to care about what was happening. Now, 70% were able to publish this in some way, but only 57% that came through again. Only 57% did it to a broader base, the parents and the community. And the real strengths and the real gaps that were found in here were real to them. And that's probably the most important thing, because if they think, oh, this really isn't us, I don't care what that says. You know, any evaluation tool is sort of like that. And 65% felt that the process did really help them pinpoint their priorities and what they really needed to focus on. And the students actually do have to make some decisions in what is most important and what can they do. And the actual school health index process with the ranking their actions according to cost, time, effectiveness, feasibility, and importance actually did help them decide, well, you know, even though this is very important, we don't have the money to buy a new curriculum, for example. Okay? It just isn't going to work. So it did help them to really tease out what really needed to be done. And it was very nice to see that most of them would agree to have a second assessment, and we've done several of those. And the major concerns in doing the assessment is the time commitment, and some schools we had just done when they went back to do this assessment, and so it was too soon for them to know. But we do it now in 2 3-hour blocks. We will go in the first day and do all 8 modules, the discussion questions in all 8 modules. We take no breaks. They have to take care of themselves as they need to. And go back the second time with all of their strengths and challenges typed up, and they rank order the actions that they pick what they want to do. We make some recommendations. They pick what they want to actually focus on, and they rank them according to those 5 criteria: the cost, time, effectiveness, etc. We used to do it 4 or 5 1.5-hour sessions, and you know how that is after school. People come in, they're late. Yeah, right. So we found that this model works much better. And these are some of the things that actually happen. And I'm not going to spend a lot of time because you have them in your handout, but these are actually the kinds of things, the changes that schools made as a result of the action plans because of their assessment. And you can see a lot of them relate to policies, to physical education and nutrition, physical activity and nutrition. Okay? A lot of changes were made. These were things they reported doing after they got their assessment back. Now, some of the barriers to actually doing it, we asked, well, why some schools didn't do some of the changes that were recommended. And it was that they felt that there wasn't a commitment on the part of all staff. And part of that is due to limited resources, when you just have so much time and so many dollars. But also, there are sometimes other priorities in schools. No. Okay, like what gets tested. Okay. And the ability of some elementary schools to allow the investment and time follows with that, because when you're told that you have to, this test is coming up, it's pretty hard to say, well, what about health? Okay, or physical activity. And sometimes the institutionalization didn't happen because of the lack of a health coordinator. Not necessarily because there wasn't one named on paper, but one who had the time and the interest and the inclination to actually to be the cheerleader that Bonni talked about. And sometimes administrators get stuck with, like a curriculum and instruction director gets stuck with also being the health coordinator, and he's got all these other curricula to look at. And so there are too many other priorities. Or, this was a big one, and it's been alluded to before. Sometimes when you just get your administrator on board, what happens? Yeah, or they get a promotion, they go up the ladder. And you just get everybody all educated. It's just like the kids in your classroom. Every year you have a new crop. You have to assume that you have to prepare them the same way. So the administrative shift was our biggest challenge. And there are also staff turnover. Every year I would send out an invitation to people in the district when I worked for Cortland City Schools. And I'd say, this is what we're working on this year. Would you like to apply to be on our wellness team? Okay? This is what. So there's a little different perspective. So they're not, it's not a life sentence. You signed up to be on the wellness team and I'm going to be here forever. Okay? But we're working on something related to what you're interested in, and so you're more inclined to. And sometimes even the coordinator really didn't have the background in the coordinated school health model. When you think about all the people who are named coordinators in their district, you can understand how that happens. And feedback to parents and the greater community was limited, and we mentioned that before. So where do we go from here? We're looking at doing some sort of an evaluation of this whole process of how we relate to other schools that we're working with, how the university is working out in terms of this relationship. And that's an important piece to look at, because that's very important to us. I think it gives the students, and Amy could probably speak to this as well as anybody, I think it gives the students in the class taking the course an opportunity for a real life experience. And this actually is something that a school district is going to use. And after you get done with this assessment, one of the things that you may want to do is have us do a repeat assessment, but you also may want us to do a HeatCat, or you may want to do a HeatCat. You don't do the HeatCat. But you may find if your health education module scored low, or your phys ed module scored low, that you want to then use these tools, and you would call in somebody like Sandy. Okay? But this is a great baseline tool to get a comprehensive assessment of every component of your program, so that you can see where do you go next. And then if you find out your policies are kind of you may want to do the WellSat, and you're going to hear more about that next from Jackie. But we also, in our New York State Healthy Schools Leadership Institute, we also looked at the Robert Wood Johnson Foundation's Bridging the Gap analysis of policies that were implemented the first 2 years of the mandate that said you have to have a wellness policy in your school. And it concluded that those policies that were put into place, just to take care of meeting the mandate, were weak and fragmented, to say the best. And that the provisions for monitoring and enforcing and doing all those things that were going to get the policy reviewed and looked at and updated weren't there, and that they really didn't even require the schools to take any action. They were very, very weakly worded. And the opportunities to strengthen the policies in the coming years weren't prompted because you didn't have any requirement that they be reviewed. So the bottom line was that we found that the strong policies really had the strong wording, and the weak policies had the weak wording. So if you say, well, you might, or you should, it wasn't as effective as saying, we will do this. We will offer healthy foods in our vending machines, for example. So some general findings. It failed to provide children with what really was the bottom line. We wanted healthy foods and the physical activity that they're going to need to be able to learn and grow, and always put in there, achieve. If you can link whatever you're doing to school achievement, then that helps the other partners in the school to buy in. Requiring strong nutritional guidelines for the meals. That happened, but what we found is the food in the school, and there's lots of food in the school outside the cafeteria, was weak. The things a la carte even were weak. The vending machines, the school stores, the sporting events, the parties, okay? And most kids, therefore, had access to junk food and soda throughout the school day. in most of the schools that were evaluated. So the bottom line, you can see here, they just didn't have any teeth in the policies. So that's where the WellSat comes in. And that was in the Healthy Schools Leadership Institute. We took our second cohort of 19 schools, and we took their wellness policies, and we looked at them. And they were in the institute 2005 to 2009. So they were in just when, at 2006, remember you had to have the policy, all right? And we used the Rudd Center tool that Jackie's going to be talking about, and we looked at them and assessed their policies, and it's not, the WellSat tool, as Jackie will probably explain to you, it's not assessing the degree to which your school district actually implemented their policies. There's a big difference in whether you got a policy, even if you had a strongly worded policy. And sometimes I think school districts, they're afraid to put strong wording in there because then you can't enforce it. Okay, so you put weak wording in at least. Okay. So this is what we found overall. Our schools pretty much mirrored the schools. We were a little stronger and had more components than many schools, but we needed to strengthen our language and our policies, and the individual results are being sent. I think Stephanie just had a baby, so I think she was trying to get it out before the baby arrived. So there were opportunities for improvement in our schools even, and we have to ensure that nutrition education is in that policy. You have to be sure you write that as a component of your comprehensive health education program. You need to be sure you restrict food marketing and advertising in your schools and improve the nutritional quality of the requirements of the foods that you serve. Now, these are things, and I'm not going to go over this, but I put them on this slide so that you can use them this afternoon when you're looking at your policies. These are the things that we found were the biggest areas for growth. And if our schools that were in the Institute needed these things, probably chances are your schools are. Okay? So when you get your policy and you're working on it this afternoon, take this out and check off if you have these things in your policy, and this one too. Okay? So the WellSat Cohort 2, really this report is a reminder that simply having policies isn't enough. It's not enough to just have a policy. If it's not enforced, it's not effective, and you might as well start from square zero. So Stephanie Gray did our WellSat evaluation, so if you want to talk to her, she's there, and I'm there, and I thank you, and I'm open to any questions. I really ran through it fast. The partnership with the schools in our area is something that you can replicate. We have a marvelous health department. We do a lot of community work, and I think it's good for our students because they're getting hands-on, real-life experiences, and I think it's good for the community because they're getting a service that they wouldn't necessarily be able to provide to themselves. So look for some place in your community that might be able to do the same thing. And I have a model. We can send you models. You can't use the school's names that we have in there, but there's a model for you to use. You don't have to reinvent the wheel. Amy, do you want to say anything? Amy was one of the authors of this.
It was a wonderful experience, and I just, it's hard because our school districts all have taken hits budget-wise this year, and when we were designing this for them, I was one of the few in my class that actually was in a school district, and I kept saying, guys, you have to remember, they don't have any money. You have to be digging deep and providing them with resources, and I actually purposely picked Module 7, which was health and wellness for the health promotion for staff, because we are the last ones that you think about. We're all about the children, but we have to remember that if we're not healthy, we're not doing them any service. So that's my bandwagon, stress management and health promotion for staff. But I made sure when I wrote my module that every idea I pitched to the school district didn't cost them anything, and I even went online, gave them all the paperwork that they would need, exercise logs, start a walking club, everything I suggested wouldn't cost them a thing. So it was a great experience, and to know that this school district may or may not use what we pitched, but that we all were a part
Well, you
of
see
something
the
that
research.
could potentially help them.
Yeah, the research that Donna and Bonnie did shows that the schools do listen.
Yeah, that was
They
cool.
do. They have to pick and choose what they do, and it may take them a little time to implement it, but they do. Most of the time, schools really want what's best for kids.
Okay, I